Okay. Hello and welcome to the California Cancer Caucus virtual legislative briefing on underserved communities, diversity and inequities in California. My name is Daniel Stoney Anderson. I'm the president of the California Colorectal Cancer Coalition, and I'm pleased to moderate today's briefing. The goal of the California Cancer Caucus is to develop a continuous line of communications and education between stakeholders and health policy decision makers as a resource for all cancer-related public policy. A few housekeeping items. You will notice at the bottom of your screen, you will see a toolbar where you can mute and unmute, turn video on and off, and submit questions in the chat box. We're going to save all questions to the end of the briefing, so please keep your line muted to reduce any background noise. I'm very, very pleased to introduce our first speaker, Senator Anthony Portantino, who represents California's 25th State Senate District, which stretches throughout the San Fernando and San Gabriel Valleys. He has supported public health, public education, mental health, sensible gun control. His accomplishments include authoring legislation that created California's umbilical cord blood collection program, push back school start times for middle and high schools, ban the open carry of handguns on the main street, California, and raise the purchase age of firearms to 21. We really appreciate that he's done this. And he also placed a suicide hotline number on students' identification cards. In addition, he is the author of SB 987, and he will give an overview of this bill, of the reasoning behind the bill, and what it will accomplish, and how the success will be measured. Thank you, Senator Portantino.
Well, thank you for having me. Obviously, this is a very important discussion that we're having this morning. You know, bringing cancer care, cutting edge cancer care to those who need it, cutting down on the disparities between access issues, and frankly, that's one of the reasons why I authored the bill. I mean, we shouldn't have a system where only certain people get access to the finest and best, most modern treatments. And so, you know, I was surprised at the disparity. I was surprised as I learned more of patients who could not access certain treatments. And so that was the genesis behind the bill. So I was happy to partner with the California Hospital Association and City of Hope and other renowned cancer treatment centers around the state of California to introduce 987. I want to give a big shout out to my staff for working on the bill, getting it up, helping me get it to the governor's desk, and ultimately getting a signature. You know, so many people can benefit from emerging therapies, clinical trials, appropriate cancer treatment. As you all know, I mean, you're the experts, you know, with leukemia, myeloma, lymphomas, pancreatic cancer, all kinds of different type issues. We need to make sure that people have access. And more, as I'm out in the community, I hear of, people fighting, having a family member dealing with these issues. And so with the disparities, the access to specialized care became a paramount goal. And so 987, which we call the California Cancer Care Equity Act, ensures that Medi-Cal beneficiaries who receive complex cancer diagnosis have the choice to seek treatment at a comprehensive cancer center. And that's the goal, giving the patients that option to seek this care. Californians insured with Medi-Cal currently suffer worse than average outcomes of cancer diagnosis, including lung cancer and breast cancer. By increasing the access helps reduce disparities. We can have the most vulnerable of our state have this access. And if we don't, obviously it's going to result in connecting patients to the wrong care or finding out about a diagnosis that's too late to help them. And that's the other thing. Getting access to expertise helps with early detection, which obviously you all know helps with a better prognosis. Every Californian diagnosed with cancer deserves a chance to access this treatment. So as I said before, I couldn't believe the nature of that problem. And when we drilled down here we are. So there were 187,000 Californians diagnosed with cancer every year, and thousands of them will be misdiagnosed or placed on inappropriate or ineffective treatment. Patients receive care from a designated specialist. Patients who received the proper care saw a 53% reduction in the odds of early mortality. And less than half California cancer patients receive the care aligned with the national guidelines. So here we have a problem where only less than half of our patients were getting the appropriate care. Only 8% of eligible cancer patients nationally enroll in clinical trials. 8%. We can do better than that. And that's what 987 is going to help do. Obviously, the advances in science continue, and our research institutions continue to come up with more and better and more appropriate and more effective tools. We should make sure that everybody has access to that toolbox. Obviously, I want to give a shout out to City of Hope and Dr. Alvarnas, who's I know is going to discuss more about the bill, and it's been a great partnership, and I've been proud to represent City of Hope all these years. It's been a great partnership, and here we are. Mother Teresa said, when they tell me my efforts are but a drop in the ocean, I say, isn't the ocean better off for that drop? Well, with 987, we've put more than a drop of water in the ocean. We've made a difference in a lot of people's lives prospectively. And, if you save one, you save society. And so happy to have authored it, and pleased to be here to share, and thank all of the advocates and the experts who champion this cause. And here we are. We got a successful signature and implementation. And so pleased to be here. So thank you.
Well, thank you so much, Senator, for authoring the bill and everything you've done. And our next speaker is one of the partners, Dr. Joseph Alvarnas with the City of Hope, and he will discuss now that SB 987 is law. What's next?
I'm going to start by thanking Senator Portantino for his amazing vision and passion that helped make this a reality. In addition, thank the extraordinary professionalism, passion, kindness of his staff, who really made this a doable process. I think in those moments when we sat there not knowing if this could move forward, having them available to us in the ways that they were was absolutely extraordinary and elevating. And again, I take amazing inspiration from the words of the senator in thinking that this is just one step forward towards realization of a vision of true care equity for people in California. Just to give you a little bit of background, this was born really from our discussions with patients and families. And about 10 years ago, I had the misfortune of, in fairly short order, having to pronounce dead 3 patients who got to care way too late in their course. One with acute leukemia who's repetitively misdiagnosed, another one with complications of a prior transplant who died of complications of transplant that had also been missed within their system and could never get into the right care, and a third who'd suffered a relapse of prior treatment. And again, despite her pleas to her healthcare network, could not get in. So right care at the right place at the right time makes a massive difference. And one of the most graphic examples, I think, of how much oncology has changed is, again, something that the senator mentioned, multiple myeloma. Back in the early Mesozoic era, when I was just beginning my residency, it was about 1990, median survival for people with multiple myeloma was 18 months. I cared for many people in their 30s who died in a very short period of time with multiple myeloma. At places like City of Hope, median survival for multiple myeloma now well exceeds 10 years. And that's because of the availability of new therapeutics and immuno-oncological drugs on clinical trials. And these are the things that shape and change our future. So the beauty of SB 987 is that it does 3 things, 3 very powerful things. One, it level sets this idea that cancer is so different, and the immediacy and need for differentiated care overrides other considerations that have gone into the design of the healthcare system and of narrow networks. The second thought is that for those patients who have exhausted standard therapeutic approaches, there still can be extraordinary hope realized through well-designed clinical trials that can bring innovative therapeutics. And I can see in my mind at this moment the faces of patients with Hodgkin lymphoma and multiple myeloma and acute leukemia and a slew of other conditions, including lung cancer, whose path forward to survival was framed by the availability of an innovative therapeutic on a clinical trial. And I think we shouldn't understate the power of those things. The third thought is we shouldn't ask patients to fight two simultaneous protean battles. One is their battle against cancer, and the other is far too often an unnecessary battle against the healthcare system. What SB 987 has done through its realization and signature by the governor has created a real path forward for patients and families. Right now, we are collaborating in concert with others who led these efforts, with the Department of Healthcare Services in California, trying to establish the rules of how this will be operationalized. Simultaneously, we've been working with patient advocacy groups, because if patients have this power, it is not powerful unless they realize it. And educating patients and families, particularly from those in communities who may never have heard of City of Hope or may not know what an NCI Comprehensive Cancer Center is, to give them the resources that they need to request a timely referral, is the next step in empowering patients and families to have that transformational ability to reset their cancer journey for the better. What we all seek and what we desire is a restoration to wholeness. This bill, now a law, gives patients a path towards accessing care technologies and expertise that may not exist within their clinician's home situation or even within their region. And it establishes this as an affirmative right for patients and families. The other thing that we see this as is an important step in recognizing that the path towards a restoration of a wholeness with a person with cancer begins with respecting them, their family, their choices, and also helping to provide them with the tools necessary to navigate that journey in a way that doesn't result in their dehumanization. Our model to date has relied upon erecting barriers in front of patients and families as a way of, applying brute force methods in our healthcare system that ill-serve cancer patients. This law does an extraordinary job of removing a significant portion of these barriers and establishing a path forward. So what we're looking toward is collaborating not only with other academic centers, but more importantly, patients throughout this state who are at risk and who have these needs. And also partnering with all of you on this call today to see what we can do together, because this isn't one drop in the ocean. I think together we can create an enormous wave that can empower patients and families with what they need when they need it in ways that not only improves their prospects for cure or survival, but better humanizes the nature of that journey. So again, I want to thank the Senator and his extraordinary staff for marshaling this forward. I want to thank all of you for taking the news of this amazing new law forward to your respective communities, your colleagues, your friends, your family, because getting the word out is the next important step in this process. So thank you again for the opportunity to participate in this call.
Well, thank you, Dr. Alvarnas, so much for helping get this bill through. And we'll move on to our next speaker. It's Dr. Reverend Tammie Denyse, and she's co-founder and president of Carrie's Touch. And she will speak on the importance of clinical trial recruitment from the patient's perspective. Dr. Denyse.
Well, thank you so very much. And thank you all for the amazing work you're doing. I almost feel like I don't have anything else to say, because normally I'm the only person on a call that's championing the message that we have got to diversify clinical trials. We have got to make the patient experience more engaging. We've got to do all of the education and all those things. And Dr. Alvarez, between you and Senator Portantino, you've kind of already said it, and I'm here and I'm excited about this bill and excited to be here. Just a little bit about my story. Before we get to my story, I do want to highlight, some of the statistics around Black women and breast cancer. We are still dying at 41% higher rates than white women who are diagnosed with breast cancer, even though we are seeing increases overall in survivorship. So what intrigues me about this conversation today is that we get an opportunity to finally start peeling back the layers of the onion and saying, okay, well, if cancer survivorship overall is getting better for all patients, why is there still that disparity? And that's where clinical trials come into play. I think that not only do we need to incorporate other communities in clinical trials by educating and talking about things like Tuskegee that has paralyzed communities for years. And knowing that the Tuskegee syphilis trial just ended, just a few short years ago, that ran for 40 years, it still paralyzes the community. And when we talk about these things, we educate our communities and I can't remember which one of you said it, but we empower patients to be able to make informed decisions about clinical trials. When I share about participating in a clinical trial 18 years ago, I know that I'm an anomaly. I know that most patients are not going to challenge their doctors when the question is asked, how are women that look like me responding to this trial? And the oncologist says, I don't know. And I pushed back and I said, that's unacceptable. And I need to speak with the researchers. And I met with the researchers. We scheduled a 1-hour appointment. And 4 hours later, we were still there going through every page of this 32 pages of possible side effects. So I don't want to scare anybody about, the fact that the possible side effects was 32 pages, because there are side effects for any drug that we take, and they have to test them. If you use Tylenol, there was a clinical trial for Tylenol, and there was a stack of possible side effects with Tylenol as well. But every patient is not me. Every patient is not going to stand up to a physician, because physicians are people with power and with authority, and especially in the Black community, it just there's a lot of fear that's in the community. And so I am in honor to be here, to be able to start to open up that conversation and talk about how we bridge that gap, not only to get more patients of color in clinical trials, but to do specific studies on patients of color, to start to do a comparison to see why are patients of color, Black patients, responding in this way to a specific clinical trial, and then why are the majority of participants who are typically white that participate in a clinical trial, why are they having different outcomes? Because you're right, Dr. Alvarez, we want to make sure that the cancer experience is better for all patients, not just one select group of patients, and to give everybody an equal opportunity to thrive beyond a cancer diagnosis. I am a huge fan of clinical trials, because I still say that clinical trials saved my life. I had the opportunity to have some of the best care available. I had multiple eyes on me. I went through the trial. My doctor said I was the sickest patient he had in his 20 years as an oncologist. How about that for motivation, right? But what I knew was, if I died, they would have some statistics on at least one Black woman that might help them do a spin-off study, because there wasn't that 2% margin for them to do an alternative study on a different population. So I am grateful for this work we're doing. We need more legislation like this. Consider Tammie, Denyse, and Carrie's touch a part of this team, and let's continue to do this work together to advance the efficacy of clinical trials in communities of color. Thank you.
All right. Well, thank you, Dr. Denyse. And remember, if you have questions for any of our speakers, just put them in either the Q&A or the chat box. And now our next speaker, who I think will have slides, is Dr. Alain Monnereau. He's the Research Program Director and the SEER, S-E-E-R, Principal Investigator for the Cancer Registry of Greater California at the Public Health Institute in Sacramento. And he's going to present on inequities reflected in the California cancer data. Thank you, Dr. Monnereau.
Good morning to everyone. Today, I wanted to share with you some observation and facts around cancer data and inequities. Next, please. First, regarding the cancer burden in California, in 2022, nearly 190,000 Californians were expected to be diagnosed with cancer. More than 60,000 Californians died of cancer. But one thing that is important to understand about cancer is that cancer is not one disease, but brings together many different diseases. And the progresses in cancer knowledge change the way we define cancer entities. Cancer is more becoming a myriad of rare molecular diseases. Next, please. However, we may rank the top cancer site in California according to the rate and number of new cases that are diagnosed each year. We call that incidence. I will come back to that. For women, it's breast cancer, which is the most frequent cancer, and for men, it's prostate. In men and women, lung cancer and colorectal cancer are respectively 2nd and 3rd position. And 4th and 5th top cancer site are uterine corpus and thyroid for women, and melanoma of the skin and bladder cancer in men. In terms of mortality rate, lung cancer is far the most frequent site for both men and women. Next, please. So how do we know that exactly? Next. The cancer surveillance data in California come from a unique surveillance system, the California Cancer Registry, that was built around 3 regional registries implemented in the early 70s for the Greater Bay Area in San Francisco, in the early 90s for Los Angeles region, and finally in all the rest of the territory of California in early 2000. This is a CRTC that I lead. This system registers all the new cases diagnosed in all the Californian citizens. So it covers more than 40 million inhabitants. And so the CCR is the largest cancer registry in US. The small map of United States on the top side of the slide shows a map of cancer registry that are labeled by the National Cancer Institute. Next. For my topic today, I choose to share with you some facts on Cancer California for major cancer sites and from the most recent period of time available. I pick up 2 indicators, important indicators, incidence and survival. Incidence is number of new cases in the population that we describe here, California. We will observe the incident trend over time and disparities across race and ethnicity. The second indicator is survival and corresponds to the percentage of survival after a period of time after diagnosis, usually 5 or 10 years, depending on the aggressiveness of the disease. We will also observe the trend and disparities across race ethnicity. The purpose of incidence is more to assess cancer risk tracking and the dynamics of the spread of the disease in the population and questions equity with respect to risk factors, whereas survival is more an indicator of effectiveness of care, and we will question the equity with respect to access to the healthcare system, of course, and its effectiveness across race and ethnicity. Next, please. On the left side of the panel, you may see the top 5 cancer sites in California for most recent period of time, which is 2015 to 2019, and in both sexes and all race and ethnicity. We can see that breast cancer had the highest incidence rate, and then prostate, lung, bronchus, and colon and rectum, and melanoma of the skin. On the right side of the slide, you will have the estimated number of the new cases for the last year, 2022 in California. And the 5 cancer sites represent more than 55% of all new cases diagnosed in California during the same years. Next. For the next few slides, I will present each cancer site in 2 or 3 slides in the same way. On the right side of the slide, you will see a figure illustrating the indicator. Here it's the incidence. And on the left side, I summarize the significant fact. The figure shows the incidence trends of breast cancer in female for the last 30 years ago, according to race ethnicity. We observed a higher incidence in non-Hispanic white population in dark blue here compared to other race ethnicity. We also observe a downward trend in early 2000 in non-Hispanic white and non-Hispanic black, partly explained by the lower prevalence of hormone therapy. The incidence trends after 2005 is increasing moderately for all race ethnicity, but it is more important in Asian American and Pacific Islander and Hispanic in light blue and green. One explanation to this recent higher incidence is the increasing prevalence of excess body weight and declining fertility rate. Overall, we observe disparity here in incidence of breast cancer. Next, please. The slide is presenting the 5-year survival for breast cancer diagnosed between 2000 and 2018. The figures show the survival rates from diagnosis to 10 years after diagnosis according to race ethnicity. So what are the facts? 5 years after diagnosis, breast cancer patients have a good prognostic, which is nearly 90% of patients are alive, but we observed a lower 5-year survival in non-Hispanic black, 81% in pink on the figure in comparison to non-Hispanic white, 92. We observe a survival gap of nearly 11% at 5 years, which is larger 10 years after the diagnosis. Disparity in survival are likely due to tumor characteristic at diagnosis, hormonal receptor, and also to a difference in screening participation and consequently state diagnosis or access to novel treatment. Next. The third slide on breast cancer shows on the right the trends in survival rate over time between 2000 and 2019 in black and white patients. We observed that the 5-year survival of breast cancer improved slightly during the last 20 years. The observed disparity in terms of survival between black here in blue and white here in green were higher in early 2000. The gap in survival is narrowing, but still persists. Next, please. The next couple of slides are dedicated to prostate cancer. The figure shows the incidence trend of prostate cancer in male for the last 30 years, according to race ethnicity. So the important observation to report here is a higher incidence of prostate cancer in non-Hispanic black here in orange compared to other race ethnicity. We also observe a downward trend in incidence beginning in early 90s until 2013, likely due to less PSA testing. Here also we show disparities in incidence. Next, please. Regarding survival for prostate cancer, the figures show the survival rates for from diagnosis to 10 years after diagnosis, according to race ethnicity. 10 years after the diagnosis, 96% of patients are alive, which is a very good prognosis, but there is an increasing gap in survival rate between 5 and 10 years after the diagnosis between race. The Asian and Pacific Islander, Hispanic and non-Hispanic black having lower survival. I won't show you the trend in survival over time because survival is stable during the last 20 years. Next, please. The next 3 slides will present some results on lung and bronchus cancer. The first slide is about incidence trend and disparity. The major comments are a higher incidence in non-Hispanic Black male in orange on the figure, and a downward trend during the last 30 years, likely due to less tobacco smoking. I won't show you the figure in women, but the observations are similar, except that the incidence in women is lower than men, and the downward trend is more recent. So we also observe here disparity in incidence. Next, please. Here, the figure on the right shows the 5-year survival for lung and bronchus cancer cases. Lung cancer, as we all know, has a poor prognosis. 5 years after diagnosis, only 18% of patients are alive. We observe a higher 5-year survival in Asian and American and Pacific Islander in green here. Next, please. Interestingly, the trend in survival over time in lung cancer in California patients increased, and this increase is accelerating, like you can see on the figure. So the figure on the right presents the trend in survival rates over time between 2000 and 2019 in Black and white patients. Although low, 5-year survival rates improved more drastically since 2013, likely due to therapeutic innovation like we talk about, like immunotherapy. The observed increase of survival over time affects both white and Black population, but disparity are still evident. The gap doesn't narrow. Next, please. The last major cancer site I wanted to show you today is colon and rectum. The figure here shows the incident trend of colorectal cancer for the last 30 years. The main observation are a higher incidence of colorectal cancer in non-Hispanic Black population. We also observe a downward trend in colorectal incidence during the last 25 years, with a higher decrease in non-Hispanic Black population the last 10 years. This decline is a result of several factors in lifestyle factors, advance in medical technology, public awareness about colorectal cancer, and effort to improve colorectal cancer prevention. So we observe less disparity in colorectal cancer incidence, but they still persist. Next, please. This slide shows the 5-year survival for colorectal cancer diagnosed between 2000 and 2018. 5 years after diagnosis, 65 of the patients diagnosed with colorectal cancer are alive. We observe a lower 5 years survival in non-Hispanic Black population, 57%. So we identify here disparities in survival that may be due to under participation on screening program leading to later stage diagnosis, as it is shown next. Like it is shown on the figure in the left part of the slide, and also to a less access to innovative treatment. Next, please. Okay, before ending this presentation, I wanted to show you some information on rarer cancer site. Here, I wanted to show you one of the several original papers that dedicated to the impact of expertise. It is on cervical cancer in women and show an improved survival in cervical cancer patients receiving cancer care at the National Cancer Institute Design Cancer Center. The figures show cervical cancer specific survival among patients diagnosed with cervical cancer in California between 2004 to 2016 by whether they received care at the National Cancer Institute Design Cancer Center. So cervical cancer patients have a better survival when treated in NCI Cancer Center. It is a recent paper for last year from colleague in California. Next, please. Now, the last two slides will be dedicated to childhood cancer incidence and survival. To remind you that in terms of incidence, brain and central nervous system cancer is the first cancer in adolescent and second in children. In terms of mortality, brain and CNS cancer is the first cause in children and second in adolescent. Next, please. Next again. Thank you. Lastly, the current 5-year survival rate for brain and central nervous system is slightly lower than leukemia or oocyte. So in conclusion, next slide. Okay. To control cancer, we need reliable incidence treatment and outcome data must be collected. So the data must be as accurate as possible and maintained in stable manner over a long period of time. This surveillance system is requiring a financial sustainability. Second point, disparity are consistent and systemic when considering cancer incidence and survival in California. Substantial survival disparity are explained by stage diagnosis, like for breast, prostate, and colorectal, but also with a neighborhood socioeconomic status and marital status. This is a recent paper that has been published for California data. Expert cancer center represent a fundamental element of the organization of care. So best access to best care is a key element to improve patient cancer survival. And lastly, I wanted to mention that breast tumor in children and adolescents need better attention to improve survival. Before ending, next slide, I wanted to acknowledge my colleagues from the different cancer registry in California. Thank you for your attention.
Well, thank you, Dr. Monnereau. A lot for us to think about and try to make better. And if you have questions for Dr. Monnereau, please put them in the chat and we'll get to those in just after one more speaker. And our next speaker is well known to me because she's on the board of directors of the California Colorectal Cancer Coalition, and it's Ogden-Smith, and she's director of state legislations for the California American Cancer Society Cancer Action Network. And she's incredible in getting bills through the Assembly and the Senate. And she will be discussing proposed 2023 legislation to improve care for cancer patients. Thank you, Autumn.
Thank you, Dr. Anderson. Hi, Autumn Ogden-Smith with ACS-CAN. And as you guys know, our legislative session is just getting started. So these bills are the bills that actually we've introduced with our partners, but I'm sure that there will be more cancer-related bills coming as the legislative session gets going. The introduction deadline is February 17th this year. So this, again, is just a cursory glance at what we're looking at for 2023 in the cancer arena. And the first topic is on the California Cancer Registry. ACS-CAN, along with the University of Southern California and the Public Health Institute, will be sponsoring measures, both budget and legislative, to secure funding for California Cancer Registry and to ensure they are able to meet the required matching requirements and finish implementation of previous legislation, AB 2325, which brings the registry into real-time reporting. So we are excited for this to happen this year. And then we have our next bill is going to be a reintroduction of Senator Limon's biomarker testing, and ACS-CAN, along with the University of California Office of the President, will be sponsoring this legislation to require health plans and insurers to cover biomarker testing for diagnosis, treatment, and management of a medical condition. It was vetoed last year, but we are moving forward with discussions with the governor's office to address their concerns. And so this bill should be introduced fairly soon. And then the final bill we have on our plates for this year in the cancer arena so far is the Oral Chemo Parity Act. And ACS-CAN will be sponsoring this legislation. There will be some others joining us in this, names yet to be revealed. And it will remove the sunset on AB 1863 from 2016, which sets co-payments for oral chemotherapy to a limit that is equal to the cost of IV chemotherapy, providing cancer patients with a better quality of life. And so thank you guys so much. We look forward to getting your support and some more sponsorships on these measures. And we look forward to the measures that our partners will be bringing forward to address cancer and affordability this year. Thank you.
Thank you, Autumn Ogden-Smith. I'm going to go now to the question and answers and the chat box. So I want you to put your questions in both. We'll start in the chat box, and does this bill also cover pediatrics, or is it only for adults? And either the senator or
So if the senator is not on, the way the bill is written,
so Joseph, yeah, you would be good.
I'm happy to do so. So the way the bill is written is that it's for all state Medi-Cal beneficiaries. Now, children are covered under a separate system. The CCG system is a bit different than Medi-Cal overall in terms of access. And access to care has been a little bit less problematic, thankfully for pediatric patients, many of whom are treated on ongoing clinical trials. But broadly, SB 987 would apply to all Medi-Cal beneficiaries with cancer. There's no age delineated within the legislation.
Okay, thank you very much. And this is from Steve Lee. It's also for Dr. Alvarez. Thank you for your advocacy on SB 987. While expanding networks for a Medi-Cal patient is an important step forward in the vulnerable population, this doesn't cover the majority of our patients on commercial or Medicare plans. Is the next legislative step an expansion of SB 987 to do provisions for all insurance plans, commercial and Medicare? Once again, Dr. Alvarez.
I really appreciate the question because, I think the way that the senator stated is that SB 987 was the first drop within the ocean. We think there are others in California who are covered by insurance who don't have this as an affirmative right. This would not only include the populations that you've mentioned, but also people who are covered by the exchange plans under Covered California. So we are actively exploring the idea of trying to expand the scope of SB 987 to include not only members of Covered California, but perhaps those who are covered through other payers. But we're in the exploration stage. And again, we would invite dialogue and partnership with everybody on this call and others moving forward.
All right, thank you. And our next question is from Michael Kuntz, and it's once again for Dr. Alvarez. I agree with Dr. Lee. Further, what has been the exploratory analysis on the impact of care volume to the systems of which we rely, UC systems, City of Hope, Stanford, etc.? Is there an expected increase in referrals? They have 1,000 referrals per year, which must be how you look at your referrals. Or 10,000, or increase from 1,000 to 10,000 or 100,000. In other words, what will be the load on the cancer centers produced by this bill? What is predicted?
So I think the load would be relatively modest. When we had originally modeled out SB 987 in its very preliminary form, and looked at the total number of patients with advanced refractory and relapsed cancers who could potentially qualify. That number was about 19,000 patients throughout the state of California. In the current form of SB 987, it models out to roughly 2,000 patients across California. And these folks are distributed throughout the state, which means that they'd be accessing care not only through the NCI CCCs potentially, but also through the NCORP sites, many of which are scattered through places that don't have an NCI CCC and qualified academic cancer centers. So we would expect for those centers that there would be a modest increase in volume from this population, but the numbers would not be dramatic if that was expressed as a concern. Our hope over time, as the first question alluded to, is to build up eligibility towards a model of what we would view as full equity for those diagnosed with cancer to be eligible for this level of care and this type of benefit. But that's something that would happen over time and would require additional legislation. The initial volumes from SB 987 would likely be fairly modest at first.
And then the second part of that question, Dr. Alvarez, was education, outreach, and advocacy should be prioritized. What are the practical mechanisms by which this is proposed to be realized, and which is it's a broad comment on this question.
It is a broad comment, a great question, and probably, honestly, at this moment, the most important question, because in order to make this real, we have to work collaboratively to educate patients and families that this is a right. Academic cancer centers and NCICCCs and NCORPs can only do so much of that. There are organizations like ACS-CAN and others, both represented on this call, and others who are not, like California Black Healthcare Network, the Latino Cancer Coalition, Be the Match, LLS, and others who are not on this call, who are extraordinary at reaching out and touching members of their communities respectively. For SB 987 to truly succeed, it has to be an interdigitated, integrated effort by all these entities, and even more to make sure that patients in underserved communities and under-communicated communities understand their right to the access of this type of care.
All right. And one other question, and this one is dear to my heart too. It's from Andrew Gale. Has the Senator's office or City of Hope heard anything from the Department of Healthcare Services, which runs Medi-Cal, about plans to provide guidance on SB 987, such as information notices or tracking it in any way? Or in other words, are you getting some help from the Department of Healthcare Services, Medi-Cal managed care?
Absolutely. The department has been nothing but extraordinarily supportive in pursuit of a successful implementation of this law. We've been engaged in conversations with them. I think Autumn has been in some of those discussions. Part of that has been involved in developing a fact sheet that could be utilized by the department to educate both the managed care entities, the plans, and the medical groups as to this. And I think the department has been very, very forthright in its desire to ensure the success of this legislation, and I applaud them for their work. They've been absolutely deeply engaged in this. I expect it's going to take time, because taking a law from something that's signed by the governor to operationalizing it through administrative rules making and communication and all that takes time. But again, the department's been extremely engaged in these conversations. And Autumn, I'm not sure if you've got anything to add to that, but I've been impressed.
No, I think you've got it down.
Okay. And then a question from Margaret Hitchcock, who helped plan this and is the vice president of the California Colorectal Cancer Coalition. COVID has directly impacted access to care at the NCI designated cancer centers, even for those of us with the commercial insurance. What is being done to help advanced cancer centers expand their workforce to allow all patients to get timely access to cancer care at advanced cancer centers? And she had some personal experience in this, and I'm sure that's why the question was asked. But I guess this is you again, Dr. Alvarez, or anyone else on the call.
Well, I can speak for one of the state NCICCC's, City of Hope, which is we've taken a multi-level approach. One was during the pandemic, we made sure that if someone was enrolled in a clinical trial, the continuity of access to that trial was never disrupted. And we used alternative means, like things like virtual visits and things like that, to continue patients on trial. The second thing is we've been building up capacity. The cancer center has been growing, and that includes hiring of new faculty, building up of additional resources, care navigators. We're now at a point of where we have more than 500 therapeutic interventional trials, in addition to non-interventional and non-therapeutic trials. So that portfolio of trials is growing. So we've been investing deeply in that. The second portion of our strategy is growing the number of sites where patients can access trials. I believe we now have more than 38 community-based practices that can be an engagement point for patients who don't live in the Duarte, Pasadena area. And we've also invested in the development of a center in Irvine that would be able to provide that kind of access to phase 1, first-in-human trials that are hard to replicate in other care settings. The third thing is looking outward towards communities and leaders at our institution, like Kimlin Ashing, had been working with community-based groups to make sure that patients in diverse communities, underserved communities, communities far from the usual academic centers are engaged really early on, initially in efforts geared at prevention and health literacy, but also geared at trying to get timely access to screening and subsequent cancer care. So I think it's a multi-pronged approach. We realize that the scope of cancer in the state of California, I expect next year we'll have 190,000 diagnoses throughout the state, may exceed the capacity of any of our centers to fully serve every patient who's diagnosed. But we're certainly growing along the lines of a strategy that seeks to deliver as much care to people who need it as possible throughout our region.
Okay, thank you so much. And I have the last question, and it's for Dr. Monnereau. And I noticed on the colon cancer slides that it looked like the incidence in colon cancer was flattening out and possibly even increasing. Can you expand on that?
Well, what we notice from this cancer is it's more a decrease between non-Hispanic Black and the rest of the population. So we observe less disparity in colorectal incidence, but the disparity still persists. And this decline is a result of several factors like lifestyle, but also screening, public awareness about colorectal cancer. So that's it. This is for incidence. If you are talking about survival, survival still there is still disparities, and this disparity is more or less explained by later diagnosis, state diagnosis. So underutilization of screening for non-Hispanic Black people.
Yeah, I'll get back to you offline, but I'm interested that I think colorectal cancer incidence is not decreasing at the rate it used to for a variety of reasons, but I'll get back to you. So anyway, I want to thank all the speakers because we started late, but we're finishing on time. So all the speakers, as well as the lively discussion, the people ask questions. If you need more information, please contact Nicole East at NEAST@mosaic, MOASC.org. So we can put that in that email in the chat. So enjoy the rest of your day. Thank you so much for attending, and thank all the speakers. All right.
Thank you.
Thanks. Good night, or
Bye-bye.
good noon. I guess it is almost.
Yes, noon.